I'd like to thank Philip and the Hong Kong team for this kind invitation to participate in this Hong Kong Live. It's such a privilege and honor to do so. My topic for this morning is on post-ERCP pancreatitis and how to prevent. In 1973, Kawai and Klassen did the first sphincterotomy for removal of CBD stones. And for the next 20 years, the complications of ERCP were not well recognized. It was in 1996, this landmark paper from Marty Freeman actually classified the complications of ERCP, and we realized that the most common complication was pancreatitis, with sometimes significant mortality also. And since then, work from several workers, including Marty Freeman, showed that there are definite risk factors which could be identified both in the patients and in the techniques which could result in pancreatitis. And therefore, if you could avoid these risk factors, you could probably decrease the incidence of post-ERCP pancreatitis. We now know that post-ERCP pancreatitis is the most common complication of ERCP, with average, in average risk patient is 5%, in a high risk patient it can go up to 20%. There are of course several factors which come into play when we try to discuss how we can prevent post-ERCP pancreatitis. For example, pharmacological agents, pancreatic stents, IV hydration, the techniques that can be used, and of course the most important is patient selection. I like to emphasize here that the patient selection becomes important because we now know who are the patients who have high risk factors. For example, if you are an young female patient who doesn't have a stone in the CBD, and if you are trying to do an ERCP for possible sphincterotomy dysfunction, the potential of producing post-ERCP pancreatitis is extremely high in a patient like this. Let's look at all these other factors which are responsible for and with which we can try and prevent post-ERCP pancreatitis. The most important first area is pharmacoprevention. There have been 35 agents which have been studied, over 100 clinical trials over the last 30 years, and more than 60 RCTs. Most of these are, however, underpowered, inconsistent, and until recently, no medication was in widespread use. And again, this classic paper from Joseph Almanza group, published in New England Journal, showed very clearly that in patients who had high risk for ERCP, and these were patients mostly with sphincterotomy dysfunction, when they used indomethacin and compared to placebo, you can see that there is a marked decrease in post-ERCP pancreatitis, especially showing those who had moderate to severe pancreatitis. And this patient didn't have many side effects when indomethacin was used, and this is quite very safe. And since then, this has been advocated in patients with post-ERCP to prevent post-ERCP pancreatitis. In fact, very long back, the ESG guidelines suggested that diclofenac or indomethacin should be administered rectally, routinely in all patients before ERCP. So let's look at the data that's there, and you can see that most of our trials are now showing benefit of using indomethacin in these patients. There's only one outlier trial, and this trial had problems. There were 30% of the patients who had previous EST, and 18% of the patients had an endoscopic ultrasound and FNA. So therefore, there were some confounders in this trial. Otherwise, we are now fairly sure that rectal indomethacin is a good prophylactic agent to prevent post-ERCP pancreatitis. Now, let's look at certain clinical questions. Should we use rectal indomethacin in all patients for preventing post-ERCP pancreatitis? What timing should we use, and what route should we use it in? Now, this was a study which came from UPenn. Nikhil Thiruvengadam and his group looked at all patients undergoing ERCP. This was actually a retrospective analysis, and they showed that overall there was a marked reduction in pancreatitis in whatever category of patients, whether they had native papilla, post-sphincterotomy group, those who had pancreatic adenocarcinoma or cholangiocarcinoma. So this study again was clearly showing the benefit of using indomethacin in all patients, irrespective of high risk or low risk. So based on the systemic review and meta-analysis of several studies, the conclusion that we could come to is that rectal indomethacin should be used in every patient unless there is a contraindication like renal failure, and it's quite inexpensive and is safe. So the second aspect is timing. When should we give rectal indomethacin? Should be given before ERCP, during ERCP, as it's usually done, or after ERCP? To answer this question, we have a rather complicated study which was published from China, in a multicentric study which came in Lancet 4 years back. These were actually 2,600 patients who were randomized to routine rectal indomethacin and 30 minutes before ERCP, and they were second group was stratified. High risk group had indomethacin and average risk did not have indomethacin, and in this group the indomethacin was given after ERCP, the standard procedure. And what this study showed was that if you use indomethacin half an hour before ERCP in both high risk and those with average risk, the incidence of post-ERCP pancreatitis comes down better than those in whom it's used immediately after ERCP. So therefore, using before ERCP is better. So the recommendation is rectal indomethacin 30 minutes before ERCP should be the ideal timing. Now, what is the route? Should we give? Can we give it orally? Can we give it IV? There are several studies again looking at intramuscular, oral, and so on. None of these studies have shown benefits of using indomethacin. Only rectal indomethacin is useful. Now, why is rectal better than intramuscular oral? We do not know. In fact, I think nobody knows. Now, coming to the second aspect, this is pancreatic stents. Now, can they be used to prevent post-ERCP pancreatitis? Of course, the concept came from the fact that in patients in whom you do a sphincterotomy, there can be thermal injury and edema of the pancreatic orifice, and this can result in spasm of this and post-ERCP pancreatitis. So, if you put a prophylactic pancreatic stent, you could prevent pancreatitis. And of course, again, the ESG guidance suggests that using prophylactic pancreatic stents can be useful in patients who are especially high risk for this. Let's look at certain clinical questions here. How effective are pancreatic stents? Which stent should be used? When to use? And should be combined with NSAIDs? Again, it's very clear that prophylactic pancreatic stents are useful. Meta-analysis showing that they are highly favored in patients who have a high risk. So, which stent should be used? Again, there have been several studies, but I'd like to summarize from this study which came from Todd Barron's unit, which showed that using 5 French 5 centimeter stent is the best. These stents not only protect but can also fall off spontaneously after about a week to 10 days time. Now, when should we use pancreatic stents? Generally, we use it in high risk situations, and one of the high risk situations is when you have patients who have a double guide wire technique is used. This is one of the high risk conditions. In patients who have had pancreatic cannulations more than 3 times you enter into the pancreatic duct, when there is high acinarization, and those patients who are potentially high risk because of either a pre-cut or ampulectomy, for example, they would be qualifying for this high risk group requiring pancreatic stent. So when we have a difficult cannulation, we sometimes put in a wire in the pancreatic duct and then follow it up with another wire, go up in the bile duct. Now, in these patients, if you don't replace the pancreatic wire with a pancreatic stent, the chance of producing post-ERCP pancreatitis is very high, and therefore this should always be used. Similarly, if you fill up the pancreatic duct, produce acinarization, or fill up the whole pancreatic duct, the chance of pancreatitis is about 8.6%, and you should consider a stent in these patients. Now that we know that stents are useful, we know that NSAIDs are useful, can we combine both of this? So there's been a concept that synergetic effect may be used when you combine all these. Unfortunately, this network meta-analysis again from Todd Barron's unit showed that when you use just NSAIDs, you get 75% protection, 50% protection when you use stents, but when you combine both, there's no synergistic effect. So we believe that combining NSAIDs with prophylactic pancreatic stents doesn't give additional benefit to the patient, and of course there's trials going on to try and look at this. I know that Hong Kong also is involved in one of these trials, but we still don't have answers yet for this, and therefore at present we don't combine both unless it's very essential. So coming to the third point, and this is IV hydration. Now, IV hydration has been shown by this very elegant study which came from the Korean group, that if you use vigorous hydration in patients who are going for ERCP compared to those patients who haven't had this, the chance of pancreatitis comes down with hydration. So this was a concept which came at what type of hydration should we use? Should we use normal saline? Should we use ringalactate? And again, this very nice study from American group showed that using a combination of lingaractate with indomethacin was more useful than using normal saline. So therefore, lactated ringer is the solution that we use. Now, why does lactated ringer help? Again, there are a lot of theories that it's got an effect against the macrophages and alkalization helps and so on. But whatever the reason, this is helpful in decreasing the incidence of post-ERCP pancreatitis. And finally, coming to the techniques, and I think this is something which has been neglected for long, but we now realize it's extremely important. For example, it's now been shown that guide wire cannulation can result in decreased post-ERCP pancreatitis. So you see that there are several studies and now again meta-analysis to suggest that if we use guide wire technique to cannulate the bile duct or pancreatic duct instead of contrast, you have a very good chance of preventing post-ERCP or decreasing the incidence of post-ERCP pancreatitis. And also the technique of actually how you handle the papilla. You can see very clearly from this study from Michael Burke's unit, which has shown that if you are actually poking at the papilla and touching it more than 10 times, for example, the incidence of post-ERCP pancreatitis increases from 4% to 11%. So in general, one would be very careful when you're handling the papilla, and more than 5 attempts should be carefully watched at, and we should not increase beyond this because the chance of post-ERCP pancreatitis increases. So what we would do in our unit, in our general practice, is that if you have a patient with going for ERCP, we would hydrate them before the ERCP, and in general, I've used about 1 pint of lactated lingeractate solution. And then of course, in all these patients, half an hour before ERCP, we'd do a rectal indomethacin. The exception would be patients who have renal failure. And in certain patients, for example, those who are going for ampulectomy or in whom I have to do a pre-cut, I'd in addition put a pancreatic stent. And during the procedure, again, we give 1 more pint of lactated ringer solution. And after the procedure, another pint of lactated ringer solution. So totally 3 pints we used in this procedure. And using this technique, our post-ERCP pancreatitis has come down from an average 9% to about 2% in our unit. And this is irrespective of how experienced a person is at doing ERCP. And I'd like to emphasize again, it's very important what Peter Cotton said very, very long back, that PRCP is the most dangerous for people who least require it. So getting the right patient, the right indication is extremely important, and I think with this we can avoid a lot of post-ERCP pancreatitis. And finally, I think if you can avoid this, is always better, because if you have a post-ERCP pancreatitis, it's something like this. This is one of the world's costliest painting called the Scream. So when you have a post-ERCP pancreatitis, not only does it become extremely costly for both the unit and for the doctor who's produced this, but also I think you have the patient screaming, the attendant screaming, and so on. I believe that if you follow these techniques, especially select your patient in the right way, if you use rectal indomethacin in all your patients, hydrate them well, and selectively use pancreatic prophylactic stents in majority of our patients, we can actually avoid this catastrophic complication of post-ERCP pancreatitis. Thank you very much.